Welcome to The Explainer. Let's dive right into a medical mystery, shall we? We're taking on the clinical challenge of undifferentiated tropical fevers. But hey, we aren't just going to stand around listing symptoms. No way. We're treating this like a high-stakes race against the clock. Because when it comes to these fevers, knowing exactly which day of illness your patient is on can literally mean the difference between a rapid recovery and a life-threatening crisis.
So here's our diagnostic dossier for today's explainer. First, the 5-day fever protocol. Second, tracking typhoid's weekly progression. Third, dengue, the danger window. Fourth, lepto and scrub typhus clues. And finally, malaria, uncomplicated versus complicated. Let's get right to it.
Section 1. The 5-day fever protocol. Okay, so on days 1 and 2, your priority absolutely isn't broad, panic-driven testing. It's actually just paracetamol, up to 6 tablets a day is totally fine, and an aggressive search for a concealed focus of infection. We're talking about things like a hidden abscess, prostatitis, or maybe pericoronitis, which is a super easily missed dental infection. Then, by day 3, you shift your brain into pattern recognition mode. Day 4, that's when you initiate empiric treatment. And if they're still burning up on day 5, you immediately order full blood cultures. No waiting around.
Like I mentioned, by day 3, pattern recognition is paramount. It's kind of like a giant puzzle. If you see a rising stepladder fever, you gotta think salmonella. Severe chills and rigors, that points straight to malaria. But what if the predominant symptom is intense calf muscle pain, like way more severe than the fever itself? Well, then you're looking at leptospirosis or scrub typhus. An early retroorbital eye pain mixed with severe bone pain? Yeah, that's classic dengue for sure.
Now, if a test hasn't confirmed malaria by day 4, you need to act. A specific combination of doxycycline and cotrimoxazole is the recommended empiric treatment here. Why? Well, doxycycline covers scrub typhus and lepto, while cotrimoxazole has excellent sensitivity for typhoid isolates. Oh, and a quick aside, but a crucial one, fluoroquinolones are strongly discouraged due to their poor sensitivity and nasty side effects. Just don't use them.
Moving on to Section 2, tracking typhoid's weekly progression.
This really shows exactly why early protocol adherence matters so much. Typhoid escalates drastically. In week 1, you've just got this manageable stepladder fever and maybe a surprisingly slow heart rate relative to how high the fever actually is. But by week 2, it invades the organs. You start seeing liver and spleen enlargement, plus those classic rose spots. Leave it untreated until week 3, the bacteria multiplying in the intestinal Peyer's patches can literally lead to life-threatening GI bleeding and intestinal perforation. It's serious business. To really grasp the sheer scale of a typhoid infection, consider this number. It takes a massive 100,000, or 10 to the 5th power, organisms to actually cause a typhoid infection. To put that into perspective for us, Shigella only needs about 100 organisms to make you sick. It's a huge difference in scale. So how do we catch it? Well, when it comes to diagnosing typhoid, the clinical guidance outright dismisses the traditional Weddell test. They literally call it a crap test. It has virtually zero reliable sensitivity or specificity. Blood cultures, particularly in the first week where they have 90% positivity, are really the only practically useful tool you have for diagnosis.
Section 3, dengue, the danger window. Now, there is a major diagnostic trap with dengue that catches a lot of people off guard. From day 1 to 4, the NS1 antigen test will usually be positive. From day 6 onward, the IgM antibody test turns positive. But day 5? That right there is a dangerous diagnostic gap. Both tests can actually come back negative, giving this deadly false reassurance to a patient who is, in reality, entering the absolute most critical phase of the disease.
And during those critical days, mainly days 4 to 7, things can spiral incredibly quickly. Platelets can dangerously plummet from totally normal levels down to 8,000, 5,000, or even 2,000. This opens the door to severe bleeding and capillary leak syndrome, where fluid literally leaks into the abdomen and lungs. The protocol makes it very, very clear. Fluid replacement is paramount here, and steroids completely lack value. They won't help.
All right, Section 4, lepto and scrub typhus clues.
These two diseases are tricky. Both start with an abrupt fever, calf myalgia, and red eyes, but they quickly diverge. Scrub typhus hands you a fantastic visual clue, a dark, scab-like eschar on the skin. You absolutely must search every inch of your patient for it. Leptospirosis, on the other hand, lacks the eschar. Instead, it hides a delayed threat, a severe week 2 immune phase that can strike out of nowhere.
even after the fever has completely subsided. And the clinical stakes of that week 2 immune backlash, they are incredibly high. These specific anecdotes from our source material remind us exactly why vigilance matters. Picture this. A 25-year-old recovering from leptospirosis suddenly developed myocarditis and needed the cardiology ICU. Another patient, literally packed up and planned for discharge, suffered a ruptured chordae tendineae in their heart, leading to severe pulmonary edema. The bacteria might be long gone, but the immune system's overreaction can still be deadly. You can't let your guard down. Finally, Section 5, malaria, uncomplicated versus complicated. If you're studying for exams, you really need to map out these key biological differences. Notice how specific genetic traits protect against specific strains. For example, being Duffy negative protects your red blood cells against Plasmodium vivax. Meanwhile, having the sickle cell trait actually protects you against the much deadlier Plasmodium falciparum, which is notorious for cytoadherence, basically meaning the infected cells stick together and clog up blood vessels.
The difference in severity between these two forms is stark. Uncomplicated malaria is rough enough, presenting with a high fever, massive sweating, and an enlarged spleen. But complicated malaria, that escalates to multi-organ failure. We're talking lung distress, brain involvement, and black water fever. And the golden rule you have to remember here, every single case of complicated malaria is safely assumed to be falciparum, no exceptions. So the absolutely crucial point is treating them correctly, right? For uncomplicated cases, oral combination therapy, like Artemether or lumefantrine, does the job perfectly. But for complicated cases, you immediately switch to a rigid, life-saving IV artesunate protocol that's dosed at 2.4 milligrams per kilogram and strictly repeated at 12 hours, 24 hours, and then daily thereafter to rapidly clear that parasite out of the system. We'll wrap up our explainer with this vital question. Undifferentiated fevers are a chaotic puzzle, but as we've seen today, these diseases leave a very precise, time-stamped trail. From the day 4 dengue platelet drop, all the way to the week 2 leptoimmune backlash. So when the next tropical fever presents, will you watch the clock, or just guess? Applying this structured protocol isn't just about passing your exams. It is the most precise way to actually save a patient's life. Thanks for joining me on this explainer, and keep asking the right questions.